Good afternoon, everyone. Welcome to NACo's National Policy Update. We're just going to let everyone filter into the room here. So just give us one moment. Well, thank you all so much. Again, good afternoon. My name is Mark Rotaco. I'm NACo's Director of Government Affairs. And as many of you are already aware, in September, the Biden administration took several key executive and regulatory actions to improve vaccination and safety protocols across a variety of employer settings. We've invited policy experts from our own NACo team and the Centers for Medicaid and Medicare Services to break down what is essentially two key sets of regulations that were released last week with regard to vaccinations and testing. That being said, we're going to hear about one of those sets of regulations and then pivot to the other set of regulations that was promulgated by OSHA. But first, on the CMS interim final rule for healthcare providers, we're pleased to be joined today by Chief Medical Officer and Director for the Center for Clinical Standards and Quality at CMS, Dr. Lee Fleischer. Dr. Fleischer, the floor is yours.
Thank you so much, and really appreciate the opportunity to brief you today and discuss the Omnibus COVID-19 healthcare staff vaccination rule. We recognize that this requirement may not impact you directly, but it could affect the healthcare facilities within your counties. And I want to start by acknowledging that patient safety is the foremost priority of CMS. This regulation and the requirements within promotes a system-wide approach to protecting anyone seeking care by ensuring that healthcare staff are vaccinated for COVID-19. I'll also note that the CMS rule was part, as was just discussed by Mark, of a whole of government approach. And I'll really talk that it's really what we're talking about is the facilities regulated by CMS and how the rules interact. So the staff vaccination requirements apply to the Medicare and Medicaid certified facilities that are regulated under the foundational Medicare health and safety standards known as the conditions of participation, or COPs, the conditions for coverage, or the requirements for participation. The COPs, conditions for coverage, and requirements for participation were established by CMS to protect individuals receiving healthcare services from Medicare and Medicaid certified facilities. As I said, safety is foundational, and protecting individuals from COVID-19 is the most important factor. We've included 15 provider and supplier types within this regulation: ambulatory surgery centers, clinics, rehab agencies, public health agencies as providers of outpatient physical therapy and speech language pathology services, community mental health centers, comprehensive outpatient rehab facilities, critical access hospitals, end-stage renal disease facilities, home health agencies, home infusion therapy suppliers, hospices, hospitals, intermediate care facilities for individuals with intellectual disabilities, long-term care facilities, programs for all-inclusive care for the elderly organizations, or PACE, psychiatric residential treatment facilities, rural health clinics, and federal qualified health centers. There are certain provider types that we did not include, which include religious, non-medical healthcare institutions, organ procurement organizations, and portable X-ray suppliers. Importantly, that those latter two may have individuals who require vaccination through the service arrangements with the applicable facilities. And our statutory authority, I think it's important to acknowledge, does not apply to some other types of facilities like assisted living, group homes, and physician offices. Now, importantly, if physicians, for example, have admitting privileges within the hospital and see patients there, then they would be covered by the hospital's conditions of participation, the COPs, and therefore covered by this vaccine. So there are three basic requirements in the way that we're viewing that facilities must complete. So this is really about the facilities and the rules of governance. One is they must provide a process or plan for vaccination all eligible staff. Those who do not qualify for medical or religious exemptions or are considered full-time teleworkers, those are exempted, and we'll talk about that more in a minute. They must have a process or plan for providing the exemptions and accommodations for those who are exempt. Accommodations could include, for example, testing, source control, physical distancing. And third, they must have a process or plan for tracking and documenting the staff vaccination. Now, there are two key phases, and you can see it on this slide. The first is at 30 days, or by December 6, 2021, where the facilities have to have all processes and plans in place for vaccinating staff, providing exemptions, and tracking the vaccinations. It also requires that the staff at the healthcare facilities included within this regulation, at a minimum, have their first dose of a 2-dose regimen or the primary dose of a 1-dose regimen. Phase 2, which you see is 60 days, which is the January 4th deadline, staff must have received the shots needed to be fully vaccinated, with the exception of those who are exempted, which I just talked about, or staff who have delays in their vaccination per CDC regulations. And we think these two deadlines really are sufficient to allow the facilities to implement the staff vaccination plans while expeditiously getting staff vaccinated as quickly as possible. The vaccination requirements apply to all eligible current and new staff, again, except those who are teleworkers, working at a facility, regardless of whether they have direct or indirect patient care. So the clinicians, as well as the EVS, dietary staff workers. The basic rule of thumb is that any staff member who is on site at a facility included in this requirement, or who could potentially interact with others who provide direct patient care, must be fully vaccinated. This includes individuals who are full-time, staff who move between facilities. For example, a nurse who actually moves from a skilled nursing facility to an assisted living facility and may have interactions with others who provide care. And individuals who may be on-site part-time, but who have full-time responsibilities for a facility not regulated by CMS. For example, that independent physician, as I discussed, the staff in their office are not covered by this regulation, but they would be. And we considered fully vaccinated to be 2 weeks after the last shot in the primary series. But for the purpose of the 60-day rule, we're viewing that as long as they have the second shot in the series, they would qualify. We want to be very clear that we are requiring the facilities to have a process for handling vaccination exemptions for the staff as required under federal law. And that this is one of the elements that the surveyors, which is the way we're actually looking at compliance, will seek to review. There are specific requirements as it pertains to the level of documentation for either a medical or religious exemption. And we're asking them to review the Equal Employment Opportunity Commission's compliance manual on religious discrimination for more information. As I said, we want to be clear that they have to have a process. We're actually not prescribing that process, including medical conditions for which vaccines are contraindicated or other reasons like sincerely held religious beliefs. However, providers and suppliers are not required to grant exemptions to staff who are not eligible, and no exemption should be provided to staff who are simply trying to avoid vaccination. Additionally, and importantly, staff who have previously had COVID-19 are not exempt from these vaccination requirements. Available evidence, including reports just recently from the CDC, indicate that the COVID-19 vaccines offer better protection than natural immunity alone, and that vaccines, even after prior infection, help prevent reinfections. And CDC recommends that all people be vaccinated, regardless of their history of symptomatic or asymptomatic SARS-CoV-2 infection. And as I mentioned in the beginning, we think it's very important that the facilities develop a process for implementing additional precautions for the staff who are not vaccinated in order to mitigate the risk. I talked about the testing, physical distancing, source control, and assigning unvaccinated individuals to non-patient care areas with low risk to patients. Importantly, we allow the facility to define, from their perspective, the best way to provide those accommodations. And a few important things, as it said as point 2, vaccination is the only option. We do not allow for testing as an alternative to vaccination. And the approach we're taking is for survey and enforcement process that ensures compliance. And the compliance will occur or be conducted by the state survey agencies during 2 periods: recertification or complaint surveys. And while on site, the surveyors will review the facility's vaccination policies and procedures, the plan for the vaccinating eligible staff, providing exemptions and tracking staff vaccinations, the number of resident and staff COVID-19 cases over the last 4 weeks, and a list of all staff and their vaccination status. This information, in addition to interviews and observations, will help be used to determine the compliance of the provider or supplier with these requirements. And finally, accrediting organizations will be required to update their survey to assess facilities they accredit for compliance with these new regulations. Now, you probably know we have a variety of enforcement remedies for nursing home, health agencies, and hospices beginning in 2022. It includes civil monetary penalties, denial of payment, and even termination of Medicare and Medicaid program as a final measure. And for hospitals, the remedy for non-compliance is termination. But I want to assure you, our goal is not to terminate facilities within the Medicare and Medicaid program. We want to work with these facilities to bring them back into compliance as quickly as possible so that every person benefits from safe and quality care. Termination is an absolute last resort, and we'll use all other levers before this is exhausted. However, we will not hesitate to use our full enforcement authority to protect the health and safety of the patients when requirements are not met in a timely fashion. Now, importantly, we recognize that there are several, and you'll hear the OSHA requirement, vaccine-related requirements for healthcare workers. So we've established a hierarchy by which to follow. So healthcare facilities are generally subject to the new federal requirements based upon primacy. So if the facility is a Medicare or Medicaid certified and subject to the CMS conditions of participation, they should adhere to the requirements outlined in the CMS Omnibus COVID-19 Healthcare Staff Vaccination Regulation. The CMS rule takes priority over the other federal requirements, and CMS's oversight and enforcement will exclusively monitor and address compliance for provisions outlined in the regulation. There are rare situations when the executive order in ensuring COVID safety protocols for federal contractors or the OSHA COVID-19 healthcare emergency temporary standard may also apply to staff who are not subject to the vaccination requirements outlined in our omnibus bill. And really, we're asking the facilities to review these regulations. And finally, we have received many questions about the interaction of this regulation with state and local laws. The bottom line is that this regulation preempts state and local and state-issued executive orders under the Supremacy Clause of the US Constitution. So we're very glad we could come here and present the rule as outlined, and we will be putting up FAQs and have guidance on how the rule will be rolled out over the next several days to week. Thank you.
Thank you so much, Dr. Fleischer, for that overview. We really appreciate it. And we will certainly be in touch with you as this rule comes to fruition. I now want to turn it over to Blair Bryant to give an overview of what this interim final rule means for counties. And again, we can't thank you enough, Dr. Fleischer, for both yours and CMS's partnership in helping local governments comply with this very important rule. So thank you so much, sir.
Thank you.
Take it away, Blair.
Good afternoon, everyone, and thank you again, Dr. Fleischer, for that overview. I am just going to take a moment to re-emphasize and emphasize some of the things that Dr. Fleischer presented on, particularly as it relates to counties and compliance. So just a few Q&As that are also a part of our FAQ document on our NACo website. So the first question is, what are all of the compliance deadlines? So the first compliance deadline is going to be 30 days after the emergency regulation became effective. So that's 30 days after November 5th, which puts us at December 6th. So on this deadline, facilities must have a process or plan in place for vaccinating staff or for exemptions and accommodations, as well as tracking vaccinations of employees. Staff must also have received their primary vaccination. So for example, if they are receiving a 2-dose vaccine, they must have at least received their first dose, or if they are receiving a 1-dose vaccine, they must have received that first dose. The second key compliance deadline is January 4th, and by that time, staff must be fully vaccinated or have filed for an exemption, and the employer must have made accommodations for those exemptions by that time. So the second question is, which employees need to be vaccinated? This regulation covers all current and new staff working at the facilities. So this includes staff that may not have direct patient contact. It also covers staff performing duties off-site. So if a staff is a part of the facility, working at the facility, and the facility is their main employer base, even if they don't work on site every day, they still fall under this regulation. And then lastly, individuals who enter the CMS facilities. So this can be a tricky one to understand, but think along the lines of physicians that travel from hospital to hospital and may see different patients at different facilities. If that physician is working in the facility, even if it's not their home base, then they also fall under this regulation. So the next question I'll go over is, how will this rule interact with other regulations and requirements? So Dr. Fleischer did go over this, but I wanted to re-emphasize it because we have received a number of different questions about it. So facilities participating in Medicare and Medicaid programs and are Medicare and Medicaid certified and regulated by CMS are governed first by the CMS interim final rule. So first and foremost, they would apply the standards of the interim final rule over anything else. Non-Medicare and Medicaid certified healthcare facilities fall under the federal contractor or the OSHA emergency temporary standard for healthcare facilities. So those are facilities that are not Medicare or Medicaid certified. If none of the above apply, then employers would be subject to the OSHA emergency temporary standard for large employers, which came out last week as well. And then lastly, the interim final rule, as Dr. Fleischer mentioned, preempts any state or local law. So lastly, I just wanted to go over some key distinctions across all of the federal mandates. It is kind of a confusing space to navigate. So I wanted to make it clear that there are 3 different types of rules and regulations that we are talking about. The first is the federal contract mandate. That mandate came out earlier before the CMS and OSHA rule in September. And this applies to full or part-time federal contractors. It's governed by the Safer Federal Workforce Task Force guidance, which you can find on our website. In counties that are receiving federal funding, so for example, if you've received ARPA funds or funds under the CARES Act, then you are not considered a federal contractor. There's distinct and very specified rules for who's considered a contractor under this mandate. And most counties don't fall under that. Exemptions and regular testing options under this mandate are applicable. So secondly, there's the CMS interim final rule for healthcare facilities. That's the one that we just went over. Again, it applies to Medicaid and Medicare certified healthcare facilities. It includes county-run hospitals and healthcare clinics. And exemptions can be made, but no testing options are made available under this mandate. So it's either vaccination or the employee can file for an exemption and have accommodations made accordingly. And then lastly, there's the OSHA emergency temporary standard. And this applies to employers with 100 or more employees in each of the 26 states that submit occupational safety plans to OSHA. Counties in each of these 26 states fall under the jurisdiction of this standard. Under this standard, exemptions and a regular testing option is applicable. So for more information on the OSHA emergency temporary standard, I'm going to switch it over to my colleague, Mike Matthews, to dive deep into that standard. Mike.
Awesome, thanks Blair, and good afternoon, everyone. In the coming minutes, I'll walk you through the emergency temporary standard, or ETS, that the Department of Labor's Occupational Safety and Health Administration, or OSHA, issued on November 4th. Leading to the issuance of the ETS, OSHA determined that workers who are not fully vaccinated against COVID-19 face a grave danger from COVID-19 in the workplace. This finding, which is discussed at length in the preamble to the ETS, really forms the basis for why OSHA deemed that the ETS was necessary and eventually issued. I'll now start with the beginning of the standard, which addresses the purpose of the ETS. The first purpose was to establish the minimum requirements for vaccination, vaccination verification, face covering, and testing, again, all of which OSHA has determined are necessary to address the grave danger of COVID-19 in the workplace. The second purpose of the ETS was to preempt state and local laws and regulations that seek to restrict employers' authority to require the previously mentioned activities in an effort to combat COVID-19. I would like to note that OSHA has expressed that the ETS does not preempt state and local laws that are more restrictive than the guidelines that are listed under the ETS. So next I'll cover the scope and application of the ETS. Like Blair mentioned previously, the ETS applies to all employers with 100 or more employees, firm or company-wide, at any time the ETS is in effect. Additionally, it instructs employers to factor in all employees, regardless of where they work, if they telework, whether they are full-time or part-time, or their current vaccination status. Notably, independent contractors are not considered a part of an employer's total number of employees under the ETS. I imagine some of you on the call are kind of wondering why counties should care about the ETS, since OSHA typically has jurisdiction over the private sector. To reiterate what Blair previously said, there are 26 states with OSHA-approved state plans, commonly referred to as state plan states, which have OSHA-approved workplace safety and health programs, but they are operated by the individual states or U.S. territories. Within these states, state and local units of government fall under the plan. So county governments who employ more than 100 people total located in one of these 26 state plan states will be impacted by the standard. If you're unsure whether your county is located in one of the 26 states, you can either go to NACo's vaccine mandate FAQ document, which includes a colorful map highlighting the impacted states, or you can go to OSHA's website at www.osha.gov/state plans for more information. Another common question has been, why is the threshold 100 employees? So according to OSHA, the specific threshold was really established for four main reasons. First, OSHA believed that employers with 100 or more employees will be able to meet the standards requirements in a timely fashion, meaning they believe that this size of an organization has the needed resources and infrastructure to facilitate the requirements of this ETS without creating undue disruption. Second, the 100 employee threshold will enable the standard to reach 2/3 of all private sector workers in the nation, and as OSHA puts it, provide them with prompt protection. The third reason is the standard will reach the largest facilities where OSHA believes that the deadliest outbreaks of COVID-19 can occur, given how easily the virus can be transmitted among individuals. And finally, the 100 employee threshold is comparable with size thresholds that are established by other congressional and agency decisions in comparable contexts. Similarly, there are situations where employees, in this case counties, with a total of 100 or more employees who are covered by the ETS, have a portion of their workforce that who do not have to follow the provisions of the ETS. And these situations include when an employee falls under the Safer Federal Workforce Task Force guidance for federal contractors and subcontractors, or in settings where any employee provides healthcare services or healthcare support services when subject to requirements of the healthcare ETS. It also does not apply to employees who do not report to a workplace where other individuals such as coworkers or customers are present, or to employees while they're working from home, or employees who work exclusively outdoors. Before switching gears and moving on to the definition section of the ETS, I imagine some of you are wondering whether if elected officials qualify as county employees under the ETS. This has been the number one question we've really received so far from our members, and unfortunately, there's no definitive answer yet. I've posed the question to our colleagues at OSHA and the Department of Labor and currently waiting for a response. So they're definitely aware that this is a question that continues to come up, and it's a priority of ours that they need to be addressed. So moving on, I'll briefly highlight the definitions portion of the ETS. Some definitions are discussed later, but two important definitions that I want to highlight now are COVID-19 test and fully vaccinated. So according to the ETS, a COVID-19 test means a test for COVID-19 that is cleared, approved, or authorized, including an emergency use authorization by the U.S. Food and Drug Administration to detect current infection with the COVID-19 virus, meaning a viral test, a test that is administered in accordance with the authorized instructions, and that the test is not both self-administered and self-read unless observed by the employer or an authorized telehealth representative. Some examples of tests that meet this requirement include ones processed by a lab, point of care tests, especially one that is conducted at a doctor's office, urgent care facility, or pharmacy, proctored over-the-counter tests, and tests where specimen collection and processing is either done or observed by an employer are both acceptable as well. Next, OSHA defines fully vaccinated as someone 2 weeks after completing their primary vaccination. So for example, if you received Pfizer or Moderna, you would not be considered fully vaccinated under the ETS until 2 weeks has passed since you received your second dose. And obviously for Johnson & Johnson, it would be 2 weeks after you received your single dose. The vaccine must also be approved or authorized for emergency use by the FDA, or listed for emergency use by the World Health Organization, or administered as part of a clinical trial at a US site. The last option is a little more nuanced, and the ETS includes other requirements for them to be considered an acceptable vaccination. The ETS also allows for mixed dose vaccinations, but again, the ETS has additional details that must be met to make it acceptable. So moving on to the next section of the ETS, which lays out the specifics of the employer policy on vaccination. So covered employers are to establish, implement, and enforce a written mandatory COVID-19 vaccination policy. A mandatory vaccination policy is an employer policy requiring each employee to be fully vaccinated, aside from the limited number of instances where accommodations are legally required. To that end, OSHA seems to recognize that many individuals have not yet received the vaccine for a variety of reasons, but implore employers to remove logistical barriers to obtaining a vaccination to incentivize employees to get vaccinated. One barrier they identified is the concern around taking time off of work, whether it's unpaid leave or using personal leave to get vaccinated. and to recover from any potential side effects. So to address this barrier, the ETS requires employers to provide each employee with reasonable time, including up to 4 hours of paid leave at an employee's regular rate of pay to receive each primary vaccination series dose, and also reasonable time and paid sick leave to recover from side effects experienced following any primary vaccination series dose. The paid sick leave to recover from side effects can be in the form of an employee's accrued sick leave if available. And then for employees who do not have accrued sick leave, leave must be provided for this specific purpose. Although the ETS tries to make it easier for employees to get vaccinated and encourages employers to implement the mandatory vaccination policy, it also allows for employers to establish, implement, and enforce a policy allowing employees to choose between weekly COVID-19 testing and also wearing a face covering at the workplace in lieu of becoming vaccinated. So to reiterate that point, employers can either have a strict vaccination only policy or could allow employees to choose between becoming vaccinated or submit to weekly testing and adhere to the other safety protocols. To ensure the employer's vaccination policies are thorough and effective, the policies should address the following applicable requirements. Specifically, it requires employees to determine the vaccination status of each employee and also maintain records and a roster of each employee's vaccination status. The employer must collect this information for every employee, regardless of vaccination status. I'll note too that all records maintained under the ETS are subject to applicable legal requirements for confidentiality of medical information. In particular, the records and associated roster must be maintained as employee medical records. But with that being said, the records and roster are not subject to the retention requirements and only need to be kept while the ETS is in effect. The section continues to go on to define what an acceptable proof of vaccination status is, and that includes the record of immunization from a healthcare provider or pharmacy, a copy of the US CDC COVID-19 vaccination, a record card, a copy of medical records documenting the vaccination, a copy of the immunization records from public health, state or tribal information systems, or a copy of any other official documentation that contains the necessary information. Essentially, any documentation should include the employee's name, type of vaccination administered, date or dates of administration, and the name of healthcare professional or professionals or clinic site or sites that administered the vaccines. Next, employers must also ensure COVID-19 testing for each employee who is not fully vaccinated and reports to a workplace where other individuals such as coworkers or customers are present. Unvaccinated employees must be tested for COVID-19 at least once every 7 days and provide documentation of the most recent COVID-19 test result to the employer. In situations where an employee does not report to a workplace where other individuals are present during a period of 7 days or more, the employer must ensure the employee is tested for COVID-19 within 7 days prior to returning to the workplace, and also provide documentation that the test result to the employer upon return to the workplace. Another important distinction to make is that this ETS does not require employers to pay for any costs associated with the COVID-19 testing. However, employer payment for testing may be required by other laws, regulations, or collective bargaining or negotiation agreements. But with that being said, the ETS does not prohibit the employer from paying for costs associated with the testing and really leave the decision-making for who pays for the testing solely up to the employer. So they could cover all, a portion of, or even none of the associated costs with testing. There's also a recognition that in certain circumstances, the employer may be required under the Fair Labor Standards Act to pay for the time it takes for an employee to be tested. Next, on the topic of testing, the ETS discusses what must happen when an employee has received a positive COVID-19 test or has been diagnosed with COVID-19 by a licensed healthcare provider. So regardless of vaccination status, the employer must require each employee who is COVID-19 positive to promptly notify the employer of their COVID-19 test result or diagnosis. Then the employer is required to immediately remove the employee from the workplace in an effort to protect the other employees from receiving the virus. After an employee has been removed from the workplace, the employer must ensure that the employee who tested positive does not return to work until the employee meets the return to work criteria listed within the ETS. This criteria is that an employee has to receive a negative result on an approved COVID-19 test following a positive result on a COVID-19 antigen test, or the employee meets the CDC criteria in isolation guidance, or that returning to work is recommended by a licensed healthcare provider. I want to note also that the ETS does not require employers to provide paid time to any employee for removal as a result of positive COVID-19 test or diagnosis of COVID-19. Again, as for the other provisions of the ETS, paid time may be required by other laws, regulations, or collective bargaining or negotiated agreements. The ETS also requires each employee who is not fully vaccinated to wear a face covering when indoors or when occupying a vehicle with other persons for work purposes. OSHA uses the same definition of face covering that has been used by the CDC. And that is a face covering means a covering that completely covers the nose and mouth of the wearer, excluding face shields, which is made with 2 or more layers of breathable fabric that is tightly woven, is secured to the wearer's head with ties, ear loops, or elastic bands that go behind the head, and is a solid piece of material without slits, exhalation valves, visible holes, or other openings in the material. Face coverings can be manufactured or homemade, and they can incorporate a variety of designs, structures, and materials. Face coverings also can be disposable or reusable and do not have to meet a consensus standard. There are some limited situations where an unvaccinated employee is not required to wear a face covering, and these situations that the ETS lays out are when they are alone in a room with floor-to-ceiling walls and the door closed, while eating or drinking for a limited time, for safety and security identification purposes, also for a limited time, wearing respirators, or when the use of face coverings is infeasible or creates a greater hazard. To be worn properly, face coverings must also completely, like I mentioned, cover the employee's mouth and nose and must fit snugly against the sides of the face without gaps. On the opposite end of the coin, an employer cannot prevent an employee, regardless of vaccination status, from voluntarily wearing a face covering unless the employer can effectively demonstrate that wearing one can create a hazard for the employee. Lastly, the employers must not prohibit a customer or visitors from wearing face coverings. So next, the ETS addresses information that must be provided to the employees. So the ETS requires employers to provide employees with information about the ETS, including workplace policies and procedures established to implement the ETS, COVID-19 vaccine efficacy, safety, and benefits, protections against retaliation and discrimination, and potential penalties for knowingly providing false information to the employer. The manner in which employers provide the required information to employees may vary based on the size and type of workplace. Basically, the ETS doesn't say you must provide this information digitally or in the form of hard copies, etc. However, it does, though, require that the information must be provided to each employee in a language and at a literacy level the employee understands. Further, when an employer's policies or procedures change, the employer must provide an updated or supplemental information to employees. The ETS then goes on to the reporting and record keeping requirements. It requires covered employers to make a report to OSHA within 8 hours of learning both that an employee has died from a confirmed case of COVID-19 and that the cause of death was the result of a work-related exposure to COVID-19. Employers are also required to report confirmed cases of COVID-19. The employer must also make available to that employee or anyone having written consent and authorization of that employee for the examination and copying of the individual's COVID-19 vaccine documentation and any COVID-19 test results required by the ETS by the end of the next business day after the request. The employer must also make the aggregate number of fully vaccinated employees at a workplace and the total number of employees at the workplace available to an employee or an employee's representative on request. Employers also must provide the written policy and the aggregate numbers of fully vaccinated employees at a workplace and the total number of employees at the workplace to the assistant secretary for examination and copying within 4 business hours of a request. All other records and documents must also be provided to the assistant secretary by the end of the next business day after being requested. So now that I've talked through kind of what the ETS says and requirements placed on employers, when does this go into effect and what happens when covered employees don't comply with the ETS? So taking a step back, the ETS took effect on Friday, November 5th when it was officially published in the Federal Register. After that date, states with OSHA-approved state plans have 15 days to then notify OSHA on how they plan to comply with the ETS, and then 30 days upon being published in the Federal Register to update their plans to comply with the latest ETS. Covered employers must also begin to implement their vaccination policy and begin to offer paid leave to employees to receive and or recover from the COVID-19 vaccine within 30 days of November 5th. And then also all employees must be fully vaccinated or begin weekly COVID-19 testing by January 4th, 2022. These were at least the dates until Saturday, this last Saturday, when the 5th U.S. Circuit Court of Appeals based in New Orleans granted an emergency stay of the ETS. In the order, the 3-judge panel said that the petitioners in the case give cause to believe that there are grave statutory and constitutional issues with the mandate. The court then gave the federal government until the close of business on Monday to respond and basically defend the legality of the ETS and express that they will expedite the case. A ruling could be as soon as this week, but there's no indication of when it might actually take place. To that end, the Department of Labor nor the Occupational Safety and Health Administration has released new information on how this court order will affect the compliance dates issued under this standard. So now that I've mentioned that, pivoting back to the penalties that I previously mentioned, OSHA may fine a covered employer that does not comply with the ETS up to $13,653 per violation of the standard. And for employers that willfully or repeatedly violate the standard can be fined up to $136,532 per violation. The last 2 highlights for the ETS, one being the comment period and the other being the length of enforcement. So the 30-day public comment period was initiated the day it was published, and they're actively seeking general comments on all aspects of the rule and also on how it would be adopted as a final standard. Lastly, the length of enforcement. Under the Occupational Safety and Health Act, an emergency temporary standard can only remain in effect for 6 months. Then it must be replaced with a permanent standard and go through the normal rulemaking process. And with that, Mark, I yield the floor back to you.
Thank you so much, Mike. There was a lot of info there, and I think the last part was actually very critical to helping understand everything you said previous. So, Mike, I think it would be really helpful for the folks on the phone to just repeat where we are right now with regard to the court stay and therefore the lack of a mandate until the courts decide what to do with it.
Yeah, basically, yeah, great. So basically, the Court of Appeals received a petition from numerous plaintiffs, and this petition for a permanent injunction was introduced in more courts of appeals than just the Fifth Circuit, but they're the ones that acted on it initially. So basically what happens is the stay that they ordered basically makes the ETS not effective until the court case has been resolved. So the big thing with this is obviously the compliance deadlines and things like that, especially for OSHA approved state plan states where they only have 15 days from publication to notify OSHA on how they plan to update their plans, and then compliance come January. So basically where we're at now, the federal government and OSHA introduced the ETS on the 5th, and then on the 6th, that next day, the court stayed it. So technically, as of now, we as in large employers are operating as in there is no OSHA ETS until the final rule within the court case is issued.
Thank you, Mike. Many of the questions that folks have asked during the course of this webinar have actually been answered in the Q&A function. So if you asked a question, you should have been alerted that that question was answered. One question on the employment side, and before I get to that, there's a few questions about that sort of take the premise that vaccines might not be effective, and therefore we don't need this standard. NACo doesn't necessarily have a position on this mandate in terms of NACo policy, but it's at least my opinion and the opinion of scientists all across America that vaccines are effective in reducing serious illness and death from COVID-19. So the question of whether vaccines are effective is really not up for debate at this point. The question of whether a mandate would be effective is something that we are looking at from a policy perspective right now. And we are attempting, the purpose of this call is to inform you in a as neutral way as possible about these federal policy updates. So on that front, Mike, question is, if an unvaccinated employee refuses to get tested, again, this would be for an employer larger than 100 employees, would that large employer be expected to terminate their employment?
So that is left out of the ETS. And I think OSHA is giving that determination to the specific employer. I think that's also why they had leniency with allowing the testing option initially, instead of making it just vaccination mandate like the other two, the interim final rule from CMS and also the guidance from the task force for federal contractors.
Excellent. So that looks like all the questions we'd be able to answer on the fly that are in the Q&A box. We will attempt to answer the more complicated ones after this call. We keep a record of the questions. We keep a record of the answers. It would be great, Mike and Blair, if you could put your emails in the chat so people can contact you directly. Oh, there you go. There's a slide for it. So that's both Blair and Mike's email. And I would also say that NACo is, of course, a membership organization, and we have strong partnerships with our federal partners. We were honored to be joined by Dr. Fleischer today. And so if you're not a member of NACo and you found this information useful, I would encourage you to shoot an email over to membership@naco.org or check out naco.org/membership to learn more about how to become a member. And I am seeing about half a dozen questions in the chat that we're going to need to follow up with, because I don't think we can answer those questions on the fly. So with that, Blair, any concluding thoughts? If not, we will wrap it a couple minutes early so we can get to answering your questions offline. Anything else, Blair?
Thanks, Mark. I just wanted to step back for a second and note that we've placed the link to the FAQ in the chat. This document has been recently updated with the information presented today on both the emergency temporary standard as well as the interim final rule from CMS. It also kind of breaks down the questions and answers based on the 3 different types of regulations that I outlined early on in the presentation. So check that out. The link is in the chat. And then I'll also flag for everyone that we have individual overviews of the federal contract mandate, the CMS IFR, and the OSHA emergency temporary standard up on our website as blogs. So you can click the links located in this slide to access those blogs and get more information about each of those regulations. I'll also note that each of the regulations has its own standards for enforcement. And so you want to read that carefully. I noticed that there was a number of questions about enforcement on all different levels for healthcare providers as well as employees and contractors. They each kind of define how the regulations will be enforced in different ways. So we'll be sure to make that distinction on our FAQ, but we want to read the regulations and the guidance carefully for enforcement information. So with that, I will turn it back to you, Mark, for closeout.
Thank you all. Thank you again so much. Thank you to our federal partners who tried to provide as much information as possible in a short amount of time. This is very complicated. We have a team of folks here who are attempting to analyze it and bring you that information just as quickly as possible. Again, would encourage you to follow up over email with our 2 experts here, and we will get back to work providing as much analysis and information as we possibly can for our counties. So thank you again. Look forward to seeing you soon. Bye.